committee meeting together. Welcome everyone. He's here, and happy early Thanksgiving. Thanks for everybody being willing to move up for the month. We'll start off to let anybody disclose a conflict of interest. You can see our policy written on the agenda. And seeing none, we'll move to the next item, which is public comment. Any public comment for today? No, ma'am. Okay, great. All right, next item up is the minutes. Has everyone here had an opportunity to review the minutes? Any corrections?
None noted.
All right, I receive a motion to approve the minutes.
So moved.
I'll second that. Any discussion? All in favor?
Aye.
Aye. Motion passes. Very important group here. Next item up is Bruce for the fiscal year 24 audit update. Thank you.
Just real briefly, we're in the midst of it. And I just wanted to let the group know that we also have a guest today, the Deputy Director from Metro Finance, who is also interested in our Kevin Brown. Good to have Kevin here. He's on our weekly calls with Metro, and he's come in here for a visit in person. So happy to have Kevin here. As far as the audit update, it's been a little bit unusual for us this year because it is all remote. We have the primary lead on the audit is a lady who's actually a remote worker with the Crossland firm, and then David Hunt, who has been the review partner on the audit for the 7 years I've been here. He's actually been involved in reviewing some of the work real time. And so he's a partner on our audit here. He's also part of the Metro audit, the big Metro audit. And I think things are moving positively. I mean, we've got a ways to go before they're going to be able to issue. But so far, I think so good. It's just a little bit unique that we don't have them physically in here where we can talk to them and hand things off to them like we have in the prior years, excluding the COVID year, of course. So anyway, I think it's going pretty well for us, and probably another month of field work to go before we wrap up.
Thank you, Bruce. Next item up is financial statements. Back to you, Bruce.
Yes, month of September, so the first quarter of the year. Just a few things on the statistical page. You can see that admissions were a little bit above budget, 226. They dropped a little bit from the prior month, but I just mentioned if you look across for the year-to-date period, we're at 682 admissions through the first quarter. That's a 7.4% increase over the prior year. That's healthy. Our observation visits are also up about 11% over the prior year. And our patient days are a little bit above budget, but what we always look at is our length of stay. Our length of stay for the year to date is 4. For the month of September was 3.6, which is excellent. I give Dr. Blackledge and the UM and the case management team a lot of credit, and also the hospitalists that manage the care and the physicians that help us move people through the system as quickly as we can. A couple of other things I would note, our ER volume for the first time since we started the no-wait ER, it dropped a little bit. We joke and call it an outbreak of wellness in the marketplace. But then on the other side, our clinic visits, 4,550, well above budget. They're just really strong. We've had some really good months in our clinics on and off site. The other nice September number was surgery cases, almost doubled budget at 60 for the month of September, and we also had 103 outpatient surgical cases, which was also well above budget. And so for the year to date, those inpatient cases are up 60% from a year ago. They had dropped significantly last year. We've been working really hard to make sure we get access and get priority to surgical cases that come through the hospital because they drive revenue and they improve people's lives, of course. The cath lab volume is well below. The cath lab has been closed for construction. So what you're seeing there is just a little bit of interventional work that can be done in the other lab, the swing lab. Deliveries actually were finally above budget for the first time in a while at 35. That's good. That unfortunately, that line is down about 17% compared to the prior year. and to budget as well. Then we move into really the financial statement side of the month of September. Total revenues, patient days were a little bit below budget, and intensity was a little bit below budget. We really didn't have cardiology cath lab because the cath lab was down, and we don't have an interventionalist, so that is hitting our revenues pretty negatively. But so in all, the hospital was about $3.5 million below budget on gross revenue. On the net revenue, a little bit better. We were almost at budget at $5.14 million. The budget was $5.19 million, so very close on our self-generated revenue. It was a good payer mix for the month. The others, so all in for all revenues, total net revenues, we were about $340,000 better than budget. That was due to a little bit higher accrual for our other revenues from state and federal sources for the month. So slight favorable variance on revenues, but then we get to the expense side, and they're pretty strong expenses for the month. $5.5 million. Our salaries are about 8.8% higher than budget, $450,000. Our contract labor is probably the other big one. It's about $350,000 higher, and we've done a lot of looking over the last really 45 days at sort of the expense line. We have 18 full-time consultants right now working strictly on Cerner. That monthly cost right now is about $330,000 exclusive of their travel and housing and so forth. So we're probably going to have that variance at least through January. Once we go live with the Cerner system in December, we will probably have to keep most of those consultants until it's stable and we've got everyone fully trained and ready to go. Sometime, conservatively by the end of January, most of them would move on and we could take that back out of the expense quotient. The other is significant variance physician services, and there are a couple of things going on there. We increased our radiology coverage contract for the trauma program. The board approved that months ago. But because the contract actually retroed back to April, we had to recognize those prior months as well in this month. Same with pathology contract that came in after the Meharry folks basically gave up the pathology coverage here at the hospital. And then cardiology call, because we have a single physician and a nurse practitioner and they can't cover call 24/7. We've had to seek outside coverage there to cover cardiology 24/7. And then the last one is just in other expenses. We've had some pretty significant IT license costs that we had not anticipated that were part of the Cerner conversion in the readiness there. About $130,000 of impact on one. And then the sterilizer and the robot lease were about $90,000 as well. Those are the two items that were not budgeted. We thought we might pay those out of capital. We were unable to do that, so those were lease expenses that we had not budgeted for. So all in, you can see about a $2.1 million negative variance on expenses. So with the 340 positive on net and the 2.1 negative on the expense line, we ended up suffering a loss of about $1.7 million. Now, as I said, there's probably $500,000 of one-time items in there, and then the $330,000 for the consultants. Those will go away, by January, but it's got our attention from an expense management standpoint as we move forward. So the loss for the month was $1.7 million, and for the year to date at about a $3.8 million loss through 3 months. So those are the September financials, Madam Chair.
Thank you, Bruce. Any question regarding the financials?
Yes, I have a quick question for you. I understand the consultant fee, that 330, we won't see that again, kind of one-time deal as we
Well,
roll out
it
certain.
will be, it'll be into December, so you'll see it October, November, December, and then January, so.
I'm sorry, when I said see it again, I meant next fiscal
Right, you
year.
won't see it this year.
Excuse me. But I do have a question about the physician services and some of those services that we're no longer able to kind of provide in-house for various reasons. I think you mentioned Meharry not covering one of those entities. So is this something that we may look forward to adjusting next fiscal year based on just, or is it too soon to say? Do we kind of have to see how we land?
They're sort of new contracts for coverage because in the case of the radiology contract, we needed more time on site for the trauma program. So basically, the physician there had to add an FTE physician, and the board approved it a couple of months ago, but because it was actually executed back to April 30th, I think, we had to acknowledge 5 months worth in September. I mean, right? And so it looks much higher than it would be on an ongoing basis. So that service is about $300,000 a month, but we had to recognize a couple of months plus the current month when we did September. The pathology one was the Meharry pathologists basically have left or retired. I mean, they have some tenured, I would say, that still work down in the lab, but for the daily coverage, we had to go out and find our own, and we can't employ, we're not allowed to employ, so we had to find via contract with a company to provide those pathology services. And so, that's about a $40,000 a month when, again, it was retro. Meharry just can't provide that service anymore. It's in the PSA, but they can't provide it. So those are the big variances that cause the physician services number to look really high for the month. I think they'll settle back down a little bit, but they were not budgeted. We didn't think we had to take over pathology or that we had to add an additional radiologist to the platform at the time. Okay.
Based on the numbers, Bruce, you said 500,000 one-time items, 300,000 contract labor that we probably won't see after January.
Yep.
Is it, assuming all other factors being the same, where do you see this?
Where do I see if
Going
this was sort of a normal?
Yeah.
Yeah, well, I would tell you the other thing that's not reflected here, and I don't want to get too accounting-like, even though we have accountants in the room, but we accrue revenue based on a 13-month rolling model based on every payer, what we typically get paid. I don't want to get too complicated. But the good news is, even though we've accrued about $15.5 million, Dr. Blackledge has collected almost $17 million. Okay, so we've collected more cash than is reflected in my financial statements. And as we keep going, if she keeps pulling in $6 million a month, that percentage that we bring in will start to float up. I mean, I hate to be, it's almost like a reserving method if you were an insurance company, and this is done in all hospitals. So we're following our protocol, and our auditors would say you have to follow your model faithfully, and we do, and they've tested it many times. By the end of the year, as we get closer to the year, Dr. Blackledge is collecting 105% of what we're estimating. We will let that number float up before we close a fiscal year. So 3 months in, I feel really good that the revenue is higher than what's reflected here, but I have to follow the process that we've always followed. So we may be 300,000 or 400,000 light on the revenue. And then I do know we've got 300,000+ on the consultants that will not be here in January, but it's got everybody's attention. We're looking at it. The other is just that we've got the Bordeaux Clinic and the urgent care center and the imaging center. There, the cost over there right now, it's bloody because it's about $100,000 a month investment, right? And there's very little because they're just getting that thing cranked up. So she doesn't have much revenue to bring in yet from the physicians or from the urgent care or for the diagnostic center because they're going through getting their contracts in place. Unfortunately, you can't get contracts with a payer until you're licensed by the state. I mean, unfortunately, that's reality. I mean, Mark's back there. It's crazy that I can't get Cigna, Blue Cross, or anybody to contract with our freestanding imaging center until I have the state license, and I can't get the state license until we're open. So you end up in this 60-day sort of spot where all you can take is cash paying patients or, patients from accident, pain, injury,
And Chair, I'm happy to add in some.
Yeah, please.
Mic on. All right. So I did not bring the typical finance report I normally bring each month. I covered September this most recent month. But I do want to take a minute to talk about what happened and where we are and what the future looks like, if that kind of gives you guys some lay of the land for us. So there are a few things. What happened is you're seeing some costs that are associated with resources. Bruce has spoken a little bit to that, but I'll go a little bit further about the things that are in flight. And when I say that, I'm talking about revenue cash. I'm talking about the cash that Bruce mentioned. And so there are a couple of things, like we receive money from patients, and we also receive money from the insurance company for the care that we provide. There are some areas where we don't receive reimbursement. One example of that is the Sheriff's Department. You guys are probably very much aware. But I'll break it out into 3 different buckets. The first bucket that I really want to spend time talking about is services. The services we provide, cath lab. I think we saw a 44% negative variance in Bruce's report as it relates to cath lab. Well, the cath lab has been remodeled, renovated. We're in the building phase. Looks good. So soon, in the near future, several weeks, we're going to see patients coming through in the cath lab. So we're going to see that go up over month, right? The second piece that I want to bring up is the off-site imaging center. Bruce said a little bit about the off-site imaging center. I'm going to hold it from there until I talk about like the sequence of events that we must go through frequently and often to kind of get in business and see patients and drop a claim. That's off-site, and by the way, we've had some good feedback too about our imaging center. And then off-site we have in our Metro Center location. I'm not sure if you all are aware, but I want to make sure and point out that we have physical therapy and occupational therapy. So we're ramping up and we're building in the community. The third thing I want to mention, or in this line, at the Metro Center location, is we have a community pharmacy present. I actually was there, I think Tuesday, and it's just a good feeling to see it and to embrace that, particularly in comparison to where it was when we began. For the future, we're looking at behavioral health services, probably the top of the third quarter. We have a small build out to do at that location. So these are all new services that we will offer within the community. Let's talk a little bit about the series of events, and Bruce talked a little bit about it. I mean, there's a lot of administrative paperwork that we must go through. For example, the imaging center, we ran into a snafu, and Dr. Brown had to reach out to one of our lawmaker friends to get our license. The state had an issue, but we acquired the license. That's one piece. We have to get a Medicaid number. That's another piece. We have to do claims updates. So I'm just walking through a little bit of that. We have to reach and touch each insurance provider and say, hey, we have an imaging center. We want to treat your members, and they have to say, okay, not okay. But there's a lot of administrative paperwork. And so we're moving to that point, and what this creates is what Bruce is mentioning, which is the revenue lag. So we anticipate that over time and seeing that. And why are these services important? These services for us, they support our triple aim in 2 ways. They improve our patient experience. Patients do not have to physically come to the hospital. They can go to us in the community, have an imaging scan. It also improves our health of the population that we serve. And those are 2 of the main points in our triple aim. The second group I want to talk about is our growth strategy. So I know since I've been here, one of the things that we've been focused on is how do we grow our volumes, how do we grow our productivity. Each of you, as business people, we look at our top line productivity for the organization. What are we doing every day? How is that working? And so for us, we are seeing growth in that area. Bruce spoke about it. We're seeing clinic volumes, and we will continue that pattern based on our operational plan. The third thing that I want to mention is operational efficiencies. Cerner is the biggest one we have. And so as we go live December the 16th, we anticipate when we move into the second half of our fiscal year, which, by the way, we did some remodeling early in the year for a lot of good reason, because we want to make sure as we're measured on our annual performance that we catch that up. So the latter part of our 6 months, we do anticipate January, February, March being much better as it relates to that piece. And then the Cerner having some expense cost, labor cost, contract employee cost associated with Cerner, we should see that ramp down. So that's a little bit of what we have in flight, where we will be seeing patients to bring some of the variants up to par, and then a little bit about the Cerner going away, and then the continued growth strategies that we have here at our organization.
Well, I want to thank you both for providing additional information, primarily in that lag, and just walking us through that process and understanding that it is, in fact, a process to get those payers on board. Being recognized by the state needs to happen prior to. So thank you for that. And then also just kudos for, I think, aligning yourself really well with the mission of being the hospital for Nashville residents. You know, we want to keep going back to that and that thought that that's what this hospital is for. And I think your community endeavors in different pockets within the community and enhancing accessibility is a really good example of that. And then, of course, that has to do with revenue. It's all intertwined. And I think it's helpful to kind of identify that and think about how that relates to the greater picture. So thank you for that.
All right. Thank you, Dr. Hudson. Anything else? Thank you.
I just wanted to add, since you mentioned the community pharmacy at Metro, if you watched Channel 5, you would have seen that we were actually featured this morning in 2 segments for the community pharmacy at Metro. It was really cool. Jeff Hardwick is our pharmacist on site there, and it's also in the process of being licensed as a specialty pharmacy by the state, right? So that will allow us to dispense, you know, I hate to say it, but the diabetes drugs and the weight loss drugs and so forth, where there's a 15 or 20% profit on every one. It doesn't have to be our patients, but it's been something we've been working on for a while. So not only will that be a community pharmacy, but it will be a licensed specialty pharmacy, which will be a nice revenue enhancement for us, and still serve a purpose in the community there for the broad Nashville community. So, for what it's worth. If you watch Channel 5, it might be on the 6 o'clock news too.
Maybe Kathy can get a snippet and send it to the board.
I love that idea. I think
that's a great idea.
Great.
Seeing that there's no other items on the agenda, we will go ahead and entertain a motion to adjourn the Finance Committee meeting. I'm sorry. Minus that. Sorry, I'm excited about finishing early.
I know.
Shocking. I'd like to receive a motion to approve financial statements for September 2024.
So moved.
I'll second. Any discussion? All in favor? Aye.
Aye.
Motion passes. And motion to adjourn?
Move to adjourn.
Second. Thank you.
Thank you.